Hi, everyone. I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Today, Faisal and I are talking about medical education. Let's dive right in.
Hey, Dr. Dan.
Hey, Faisal. It's good to be with you again.
50th episode.
Yeah, 50th episode. And I think we have a great topic today. We just seem to have academic centers reaching out every day interested in value-based care, and can we help educate the future doctors? That's very exciting.
If I had to pick something to help, to help transition the thoughts with how to approach medical education, especially with primary care, it would be around health equity and making that distinction between between improving health and improving access. Like improving, you can't just improve access without having the health. It's you got to. They're two very different things, and I feel like most of us think of improving access to care, but it's not just improving access. You got to improve health as well.
That's right. I was talking to a resident who was interviewing for a job with us recently, and they were talking about that they would like to see equal health care. And I was thinking, equal health care is obviously something to strive for, and it would be great if everybody had equal access to care. But the simple answer is to provide equitable outcomes. People with the highest needs need additional access to care. People who don't have the health literacy, it actually takes more health care to get them the same outcomes as somebody with a college education might get. So I think you and I are on the same side. We're not just looking for equal care, one size fits all.
Yeah.
We're looking for the right care for the right patient in the right location. And we feel like the PCPs are the ones who can help the patients decide what they need and coach them towards better health.
Yeah, it can't be equal when you have Americans in the low income, the minority populations, they're living in places where their life expectancy is different just based on where they're living. We've talked about this so much with in New Orleans, how the life expectancy in one zip code is in the mid 50s, and the life expectancy in the zip code next to that one, it's like 80, 82. We see that in Chicago, one part of Chicago, the life expectancy is, I think now it's like 16-year life expectancy gap based on where you live in Chicago. Similar with New York. In New York City, based on where you live, your life expectancy age gap could be over 10 years just based on where you live. So it's not about making things equal wouldn't help those who are already, they're living 9 to 20, 9, 10, 25 years less than everyone else.
Right. Well, it might help. What do you think we're looking for in our doctors? Describe what we find when we go out and hire young doctors, and then maybe what we feel like we need to add to the young doctors as they're coming in as something that people who are focusing on medical education might be interested in.
I think when I think about residency training, you're getting trained in like the best facilities on the planet. Like there's no other country in the world that has the facilities and the infrastructure that we have in place with healthcare delivery. But what we don't see in medical training is the cost of care. So like I remember learning with pick let's pick on something. Let's pick on let's pick on insulin regimens, right? Like I may go more towards a basal prandial insulin regimen, not knowing that long acting insulin could cost a couple $100, as opposed to a mixed insulin, like 70/30 insulin, that may only cost $25 for that vial, and which would also require fewer injections rather than four injections, because when I was in training, I didn't think about the inconvenience of having to inject yourself so many times as opposed to just injecting yourself twice. You see what I'm saying? Like, um, we're trained in these places where we don't know about the cost of care, and if you have complicated disease and you have the cost to be able to pay for it, then the care you get is unbelievable. But unfortunately, in training, many of us just didn't know about the cost of care delivery.
Right, and I think it's, you're absolutely right when it comes to that. I and don't you think part of it is so much of the training occurred in the hospital? And I know I've mentioned this on another podcast is when you're in the hospital, the doctor writes an order and the nurse gives the drugs. And so the patient, you know, the patient's getting the drugs. But then when the patient goes home, we've got to depend on the patient to take the drugs.
That's right.
And have we negotiated with them and come to an agreement that those are the drugs that they're willing to take? I mean, can they afford them? Are they convenient? What's the side effect profile look like? I I, I know you you talk about your dad, and I'm jealous because I lost my dad about 15 years ago, but I can remember uh, one day, yeah, a year or two prior to that, I was home one day, and on the kitchen table, he had a bottle of hydrochlorothiazide, a blood pressure medicine. And I said, "What's this? I didn't know you have high blood pressure." He said, "Oh, I don't. The doctor thinks I do, and I've got a doctor's appointment next week, so I always take it the week before I go to the doctor's appointment." And I'm like, "Does your doctor know this?" And he was like, "No, of course not. He would fuss at me if he did." So it's how do we build relationships with patients so that they trust us enough to talk to us about what they're willing to do and not willing to do?
Yeah, yeah, in the hospital environment where when we're training, the health outcomes, like so you could say, you could probably say 80% of the health outcomes are based on medical management and what tests you order. But outside of the hospital, we know that we know that most of the health outcomes aren't based on the medications and the tests that we order. We know that it's the lifestyle, and we're trained in an environment where we're giving orders and we're making sure that orders are executed, and there's a system in place to ensure that orders are executed. But that doesn't apply in real world outside of the hospital. It's only unique to the hospital system where that logic applies.
Right. No, I agree. The other thing that sort of holds back is the volume that residents are expected to see. And so, in family medicine, there's the magic number of patients that they need to see. And so they really pump up volumes, but sometimes that comes at the expense of continuity and getting to know a group of families that you're taking care of. And in internal medicine, so many of the residency programs are a 4+1 model. So they're only in the office to see patients one out of every 5 weeks. And so if the patient gets sick on a week they're not there, they have to see somebody else. And I think there's something to be said about observing the impact of illness on a patient or on a family longitudinally. And certainly volumes are important, but boy, I've always thought it'd be really cool if every resident had, I don't know, even if it was 20 families that they got assigned at the beginning of residency, and those were theirs, and they got to see them, and there was a special waiver so that they got all the cost information wherever they got health care, so that they really got to see the impact of the health expense on the family's lifestyle. You you start that $200 insulin drug, and now we can't afford to do the car service when it needs to be done. So
Yeah.
now we're breaking down on the side of the road and can't get to our job and therefore have less money. And so, I mean, we really are helping people navigate in an environment which many doctors have never truly lived in. And so how do we give that experience in a way that they can help and be visitors in in that socioeconomic environment that you're talking about.